Hello, my name is Dr. Jen Green. I'm a naturopathic physician who's board certified in naturopathic oncology. Today's series of lectures is for healthcare providers, and we're going to be covering the topics of integrative immune therapies for COVID-19 with special considerations for integrative oncology populations. I'd like to start with a quick disclosure. There are no integrative medicine trials yet on COVID-19. So none of these therapies have been validated. The research is rapidly evolving in the area of coronavirus treatment. The reason why I'm here before you is because I've been researching and teaching about integrative immunology over the past year as it relates to vaccines, cancer vaccines, and cancer immunotherapies. And there's a lot of this research, a lot of overlap, and a lot of this research applies to infectious diseases. I've been a practicing naturopathic physician for 20 years. 6 of those years have been in a hospital setting. And so it's just good for you to understand that I'm coming from a little bit more of a conservative setting when it comes to prescribing. I am the research director for nooncology.org, which is an integrative cancer database. So in this presentation, I always try wherever possible to emphasize human level research and prioritize those over preclinical studies, although there are a lot of preclinical studies listed in this presentation because that's all that we have. But especially for guidance around safety with dosing, we really want to look at human studies and what we know there. I have no affiliations with a drug company or natural health company. The following lecture just represents my educated guess as of April 14th, 2020. This lecture is for educational purposes and does not constitute medical advice. So looking at your slides, a quick overview of nomenclature, just to clarify, because you'll see these written throughout the slides. SARS is just the acute respiratory syndrome that can happen with any viral infections, and a lot of SARS models in mice will be quoted in this study. SARS-CoV plain was the initial SARS-associated coronavirus that was reported in 2003 and caused a global outbreak, which was contained by 2004. SARS-CoV-2 is the current pandemic that we are in. That's the virus that causes this current pandemic. And COVID-19 refers to the mild to severe respiratory illness that's being caused by the SARS-CoV-2 virus. And then you'll see a few sprinklings of MERS-CoV, which is a virus that was causing the Middle East respiratory syndrome, which was first reported in Saudi Arabia and Jordan in September 2012. So all of those will be cited in different ways throughout. I wanted to start with just a very brief overview of the immune system to remind everyone about the difference between innate and adaptive responses. For innate immunity, we think about that arm of the immune system that is rapid and is a first-line defense. I think about a child with a cut, all of the inflammation, redness, the phagocytosis that goes with that. That's the innate immune system. The adaptive response gets signaled by the innate response being active, and that is acquired or learned immune responses that are specific. And that specificity comes about through B cells and antibodies, and also through T cell mediated responses. T cells being our CD4, CD8 natural killer cells. And COVID-19 in particular exhausts our natural killer cells and our CD8, or sometimes they're called our cytotoxic T cells. So those cells that go after specific virally infected cells and kill them. So both the natural killer cells and the CD8 T cells are our assassins. What is convenient or interesting from our perspective in oncology is that the arm of the immune system that we're trying to upregulate to manage cancer cells is the same part of the immune system that we're trying to upregulate for viral infections like COVID. So there's a lot of overlap and shared goals when it comes to an immunological perspective. This is a brief slide you can review on your own about the different types of immune cells. This is an even more specific, detailed chart that I put together with cytokines, and the take-home message is really not to get lost in seeing the trees versus the forest. So we want to remember the overall type of immune response we're looking for, both with cancer and with viral infections, is a Th1 versus a Th2 response, even though you'll see variations in cytokines here and there. Quickly to explain what happens with coronavirus in the immune system is it uses ACE2 as one of its entry receptors. There's at least 2 other receptors that we're aware of by now. PAMPs, which we might have heard of in hyperthermia and certainly comes up with vaccines as well, will trigger the immune system to produce interferon type 1 responses. And coronavirus directly dampens this response. It's smart. It likes to propagate itself. This suppression is also closely associated with disease severity. And specifically, COVID-19 will actually suppress monocytes and natural killer cells. Our monocytes, if you recall, become macrophages in the tissues, and our natural killer cells are designed to kill virally infected cells. Interferon, in turn, induces an effective adaptive response. So a delayed or weak antibody response is associated with a severe outcome in SARS infections from earlier on. In general, we're looking for a Th1 response. And SARS, the original version, directly infects macrophages and T cells. So sort of like HIV, it hijacks the very cells that are supposed to be taking care of the infection. So it's tricky. And again, cells that we see being lowered is with this sort of functional exhaustion, as it's called, of natural killer cells and CD8 cells is associated with infectious recovery versus severe infections or death. Also keeping in mind that we want to think long-term about developing memory antibodies to the vaccine, which can happen as early as 4 days, but most patients by about 14 days after the disease onset. And long-lasting, specifically IgG antibodies, were reported as long as 2 years after SARS infection. And we're now a little more than 2 months after the COVID-19 outbreak, but we now have 37 biopharmaceutical companies working on different vaccines. So the final part of this lecture is dedicated to how to support people in getting optimal immune responses to vaccines, especially immunocompromised cancer patients, people with malnutrition, and chronic disease who might have special considerations. Also, a brief review of cytokine storm in COVID. So the critical COVID patients will have a sudden deterioration, a disease 1 to 2 after onset. They'll have much lower levels of lymphocytes, especially natural killer cells in their blood. They will have very high inflammation levels. CRP goes through the roof. You'll see high inflammatory cytokines, specifically IL-6, which we're going to get to in the treatment section. Conventionally, that's being used as a target for COVID-19 treatment. We also see high levels of ferritin, again, markers of acute phase reactants coming up. Unfortunately, you see atrophy of the spleen and lymph organs with reduced lymphocytes in the organs themselves. And instead of the lymphocytes being present in the lung tissue, you see monocytes and macrophages. And macrophages, like with cancer, have a very dual role where they can do help or they can do harm. They can steer the body towards Th1 responses or towards chronic inflammation and Th2. And then sadly, with a bad cytokine storm, you can see widespread vasculitis, hypercoagulability, and multiple organ damage. So what determines this difference between a protective versus a pathogenic inflammatory response? The difference is a relatively small difference, and it also has to do with timing. So what we're looking to do is early viral control, supporting natural killer cells and CD8 in the early phases. In the phases where things become potentially dangerous, when people are getting worse, we want to decrease inflammation and interleukin-6 to try and avoid that cytokine storm when the viral count is decreasing. And then once, if there is an established lung inflammatory pattern, we want to decrease VEGF and lung fibrosis, try and minimize that, and afterwards in recovery, encourage memory antibodies. The timing of therapeutic approaches really matters. So, in the prevention and management of mild cases of corona, which keep in mind 80% of the people who get this infection will have either no symptoms or very mild to moderate symptoms, we want to do things like support the innate immune system, type 1 interferon responses, healthy lifestyle, nutrition, exercise, stress management. Western herbal medicine is lovely. Traditional Chinese medicine has a role to play, even homeopathy. For more severe infections, we want to think about helping the body deal with the rapid viral replication. So that's where we think about drugs like hydroxychloroquine. We also want to resolve that rising cytokine exaggerated inflammation as soon as the viral load starts decreasing, and the time is unknown. Researchers are actively trying to figure out what is this window in which it's best to dampen inflammation. And best we can tell, severe patients will abruptly deteriorate within 1 to 2 weeks of onset of symptoms. So the anti-inflammatory therapy window is an extremely short window. So this is my personal opinion that many adult Americans have chronic inflammation at baseline, which is a very particular milieu that they're already in, because this chronic high level of inflammation is immunosuppressive. Recall how in cancer care, this long-term inflammation associated with cancer causes this immunosuppressive tumor microenvironment. I think that's happening in a larger scale in patients who are also non-cancer patients. And while short-term acute interferon type 1 responses are good at the beginning of an infection, prolonged chronic interferon 1 signaling leads to immune dysregulation and dysfunction. So chronic inflammation primarily caused by high NF-kappa beta, which we're all familiar with from the cancer world, and inflammasome activation is tightly linked to cancer and also to the evasion of cancer cells by the from the immune system. And that, I think, is the same exact parallel process that happens with COVID-19 in more serious infections. So I believe we should be encouraging our patients, any of them with suspected chronic inflammation, that could be from having advanced cancer, that could be from poorly regulated diabetes, that could be from toxic exposures and lifestyle, to please continue their anti-inflammatory, anti-inflammasome natural agents. Things like fish oil, melatonin, turmeric, green tea, whatever their pre-existing natural agents were to manage inflammation, to please continue taking those. I don't think that this thinking should be extended to medications that suppress fever, and we're going to get to fever in a second section, because things like ibuprofen and acetaminophen, both of which are very controversial right now, and no one seems to be able to figure out whether they are an advantage to take or not. They might actually do harm. They impact the immune system differently than natural anti-inflammatories because they're also stopping fever, and stopping fever may in fact cause us to miss out on an inflammation resolution process that happens with fevers. I also wanted to just quickly give a slide on CRP and NLR. The neutrophil to lymphocyte ratio is something that I've spoken about before and written about. It sounds complicated, but it's not, because it's apparent from any complete blood count report with differential. So it's already available. You usually have this in a patient record, so it's cost effective. It's part of routine testing. And what it highlights is how when there is inflammation in the system, the immune system will upregulate neutrophils, so surface antibacterial immunity, right? The body thinks inflammation, there's a wound. And what it does is it suppresses lymphocytes, which is our antiviral immunity and our anti-cancer immunity. And so while we see that intuitively this sounds correct and is true, that with COVID-19 patients with acute lung injury, you get, extremely high CRP levels, and that correlates with the degree of lung injury. we also see in COVID-19 patients that the NLR ratio splits. So it's significantly higher in severe cases versus mild cases. Now, what exact ratio we need to worry about is unknown with COVID. What I can tell you from cancer populations where NLR is predictive of recurrence of cancer in any tumor type that was ever investigated, and that's multiple tumor types, in general, the NLR ratio of 3 to 1 is ideal. So when you look at the lymphocyte number, if you just multiply that by 3, the neutrophils should be roughly 3 times that or less. And if you see this huge spread, you know there's really upregulated inflammation, and that inflammation is steering the immune system in the wrong direction. Some natural anti-inflammatory agents that lower C-reactive protein in human studies are listed here. And I call them double agents because in cancer care, these are all therapies that we use for various anti-cancer mechanisms that they have. So they're double agents in that they're useful in the cancer context, but they're also pretty broad, good anti-inflammatories that will lower C-reactive protein in human studies. This slide is just an overview to start us off with a reminder about our therapies. So naturopathic immunotherapy is about treating the whole person. And while we have this goal of lowering CRP and inflammation, the way we go about that goal isn't just about giving natural agents like the previous slide. It's about helping to manage sleep because that keeps inflammation down and immune system up. Manage stress because that keeps inflammation down and immune system up. Social connection really impacts immunity. The human microbiome, proper nutrition. So I have to remind us all that the foundations of our medicine, the foundations of health, sleep, exercise, healthy relationships, stress management, good food, good nutrition, avoidance of toxins, that is the same whether we're dealing with general health concerns, COVID-19, or cancer care.